Okay, so welcome. Late on day one, and we've saved some of the best for last for you. I think we've got an interesting hour ahead, and ultimately this session is going to be dedicated towards current best practices in large bore vascular closure, be that largely arterial, and also what's coming next. This session is sponsored by Vivasure, and we're going to be presenting to you not just current best practices, but also the new PercSeal device that is going to be available soon, hopefully, for large bore arterial and venous vascular closure. So what we might do just to start off is to understand how many of you are actually doing procedures where you need to close large bore access. How many TAVI operators do we have in the room? Okay, not so many. So we're going to come to you guys looking for some advice. And what are the usual strategies that are people still using two per-close devices, or people using a per-close and an angio-seal? Yeah, so a little bit of a mix. Okay, so we're going to start off the session with Lisbeth Rossiel, and Lisbeth's going to tell us a little bit about best practices and what she does in her practice and how that has changed over the last number of years. So, Lisbeth, thank you for joining us.
Okay, we're there. Good. So I could borrow this slide from a colleague from me, and I really liked it, so I used it. And it's called Finishing Strong, and I think finishing strong means to be well prepared. This means that you need to pay a lot of attention on the prep, on the pre-planning of your procedure, that you have a stepwise approach in the pre-planning, but also during your procedure, that you really have a repetitive stepwise approach. So I will go through it to the way I do it, and I think you can comment on it. So first of all, we have we look to the CT, and we look to the CT and we look for the tortuosity of this anatomy. For the access, we look to the lumen diameter. We know when it's very small that we can have more risk for complication, but also have a look at if at the arteriotomy site it's very big. We want to make sure that we still have a bailout option. And then I look to the calcium of the vessels, and we need to look not only to the amount of calcium, but also to the distribution. So the calcium can be at the puncture site, which can really be difficult for access closure and access itself as well. But the calcium can also be at the iliacs, and then we might risk some dissection, for example, or difficulties crossing the valve. The next thing we check on the CT is the femoral bifurcations. In this case, you can see that at both sides, left and right, we have a very high bifurcation, and we need to take that into account as well. As the next step, we also look to the depth of the femoral artery. In this case, you see a quite obese lady, and we have depths about 80 and 70 millimeters. This is quite a lot. And then sometimes there's other features that make access difficult. So as a next, once we have analyzed our CT and we came up with a strategy about how we will do our puncture, do we need extra devices, how will we close, we go into the procedure. So first of all, I think it's the gold standard, and we can discuss with other TAVI operators, but for me at least it's gold standard to use ultrasound-guided puncture. Because this really gives you information on the calcium, on the depth of the vessel, on the bifurcations, on small other side branches that we need to see. And we need to tailor the approach of our patients. So for me, a standard TAVI would be secondary access in radial. But for example, when we have this very calcified case and we need help from PTA or lithotripsy, there it might be good to have secondary access at the contralateral site and to put in a protective wire. So be prepared and know what you're going to do, and if needed, adapt your secondary access. Also, based on the CT, we will decide which vascular closure device we will choose. And we'll discuss this later on, but just to show that there's, in general, 3 types of vascular closure devices, either the suture-based, the patch-based, or the collagen-based vascular closure devices. Once we have delivered our TAVI valve nicely, we will do a final angio. At least that is what I do. You can also have a look with the echo to see if you have a nice patent flow in this artery. And I just show you this quickly. I won't go into detail, but this is what we do at my center. We follow the multi-close algorithm, where we have a final look with the angio through a small sheet that we access the vessel over the wire that is still in situ from delivering the TAVI. And there we will assess the extravasation of the contrast. And at the handy, what is very handy at this moment is that you still have your access. So in case you have no bleeding, you can decide to leave it like it is with the closure you've done already. But at the moment you see that you have, for example, on the right side of the screen, much more extravasation. You can tailor your approach, and maybe in this case it's good to go for a large plug-based or large plug-based or other device to end up a good clean puncture site. So these are the steps that I follow, and as an introduction to the next the following of the session.
Thanks, Elizabeth. So if you guys have questions for Elizabeth or for any of the panel around the strategies, please express them. Shout out, put your hand up, go to a microphone, use the app, whichever works for you. I'm going to start. So Elizabeth, I get into all sorts of vascular complications, and one of the reasons is that we don't have good access to general anesthesia. We don't particularly like percutaneous subclavian. I know you do a lot of it and it works well for you, but in our center it just doesn't jive. The patients that worry me the most are the obese patients with the high bifurcation, right? Because I find that when I try and pre-close them, 80% of the time the per-close doesn't work. And then even when the per-close seems to work, I have difficulty always at the end. Do you have a particular strategy that you like for those obese patients with high bifurcations, or what are when you're faced with that scenario, what do you do?
Well, you have to, if you think you will turn into a problem, you have to go from the contralateral side and put in a protective wire. So in case you end up with vascular closure device failure, you can still put in a covered stent. One of the advantages of doing the final angio is that you really can tailor the next step that you will do. And in case you turn into problems and you still see a lot of extravasation, you can even put in your large sheet and tamponade the bleeding and prepare to bail out to a next step.
So a little modification to that is you can obviously do a dry closure, where you inflate the balloon before you close the suture. That is definitely a safety measure that will likely increase your success rate of your suture closures in obese patients. What I also have been doing for the last 4 years or so is single access site. So rather than having to do a contralateral access and crossover, I use the ipsilateral superficial femoral artery as my access for a 5 or a 6 French pigtail during the procedure, and at the end of the procedure, that access helps me with the confirmation of patent hemostasis. And if something needs to be done, then it's very easy to advance a balloon or a covered stent. And with that strategy, the need for covered stents has increased to below 2% in my practice.
Raj, what about you? What cases are you more cautious? When do you say, okay, I'm not going transfemoral?
So, I mean, we've basically protocolized everything. So in every single case, all 3 operators that are TAVI implanters at my institution do the same thing every single time, which does involve having contralateral access, having an 018 wire up and over. And so our vascular complication rates with the use of dry closure and whatnot are 0.5%. We do like doing percutaneous axillary when things are, if there's a lot of adiposity in the way of the tissues, because what you'll see is that typically speaking, the axillary artery will be no deeper than 5.5 to 6 millimeters, centimeters beyond the subcutaneous plane. So a lot of times when they're obese, I think it's less risky to go to the shoulder.
Okay, so maybe an earlier transition to an alternative access, which, as I suggested, we don't do very often. Vaz, Elizabeth showed us a couple of cases there where there are stents involved. Are there any markers for us in terms of what size of stent you're happy going through, what type of stent, and then do you have any experience going through grafts? Sometimes we see these patients where they've got beautifully patent grafts, and our vascular surgeons are very loath to let us go into those.
So to start with the stents, I mean, any stent at 6-7 TAVI valves can go. In fact, I had cases where I had extreme tortuosity calcium and I had to go shockwave, normal balloon, then the thing would recoil again, and then I had to actually stent it. I go through the TAVI with a stent, through the stent. So I don't think a stent is a problem. Even a fresh stent actually can do the job. But to that point, now when I see this extreme tortuosity and calcification and I have a nice axillary, I just do perc axillary because it's so much better. And in big people and always in axillary, what I do is dry closure. What Nicola said, basically I go with a balloon exactly at the access site. And in fact, sometimes I fluoro the pusher of the prostyle, so I'll make sure the knot has gone down exactly where the balloon is. And then you kind of guarantee that you're not going to have a problem. In terms of the grafts, our vascular surgeons are the same. They're like, don't go there and don't create big holes. They're more difficult to close. We have sealed a couple percutaneously successfully, but the majority of the cases they like to come and do a mini cut down through the grafts. Yeah.
Well, I typically close them percutaneously these days, and that would be an indication for collagen-based closure in my practice. Yeah. But always do that when you have a bailout maneuver in place, just in case.
So what we're hearing is that with more complex anatomies, as long as you have a strategy up front, like Elizabeth said, be it I'm going to use a different device, I'm going to use a covered stent, I'm going to go perc-ax, have an alternative strategy so that you are getting out of there in one piece. Okay. All right. Nicholas, you're going to take us through patch-based closure and that the promise that this may offer us for the future and make our lives easier as a primary up strategy and perhaps also as a bailout strategy for arterial disease.
Yeah, thanks, Darren. So I'm going to introduce maybe a new technology to you, but technology has been around for quite some time and has been iterating. These are my conflicts. And I'm going to talk the PercuSeal family of devices. And the potential advantage of patch-based closure is that it allows you to close gaps of 14 to 24 French large hole closures. It is also fully bioabsorbable and it's patch-based closure from the inside of the vessel. It eliminates a pre-procedural step, so you don't need to do a pre-procedural depth measurement. An arteriotomy depth measurement is not necessary. And also you will not see the issues of artery pinching or abrupt artery closure, what you can get by combining sutures with angioseals and whatnot. And it is a relatively simple procedure that is easy to learn with a very steep learning curve. There are three device iterations. It's all started with the PercuSeal device, which is basically an arterial closure device with a small patch. Then there is the PercuSeal Plus that introduced a larger and a thicker patch, and now we are working with the PercuSeal Elite that introduces an 035 wire access, and that obviously is very important when you are considering bailout solutions. It's much easier to bail out over an 035 than over an 014 or an 018 wire, obviously. And this device has been scrutinized in prospective studies. So we have a series of prospective trials from Frontier 1 to Frontier 5. And we're now in the process of enrolling patients in the Elite and in the Elite Venous prospective studies that we will discuss. So in Frontier 5, the introduction of PercuSeal Plus was evaluated, and now with PercuSeal Elite, it is again the latest iteration, the PercuSeal Elite. but also we are still looking at refining the implant procedure. So a lot of patients have been enrolled prospectively, a total of 350 closures across all the trials, excluding the ELITE trial that is still ongoing. And you see the number of major access complications. This is in the line that Raj is achieving in his center of excellence, less than 1%. Also bear in mind that the operators in that study were not very experienced with the technology, so they were early adopters with this new technology. And this is a case with the Percusil ELITE from Ole de Bakker in Rijkshospitalet, where he demonstrates the procedure. Basically, you exchange your large bore sheath for the dedicated sheath, and then you introduce the system until you see the blood coming from the side port. Once you see that, you have to pull back the system until it stops, until the blood stops pouring. So he pulls back, and then he will be able to read down the arteriotomy depth. So you don't do that up front, you can do that at the end. And once you have established the arteriotomy depth, you re-advance the system for a couple of centimeters. That will allow you to release the patch on the inside, as will be demonstrated in a second. Let me see, can I go to another? So basically this is in the cartoon animation. Once you have your sheath in place, you will connect the patch system and it becomes an assembly. So you have this depth where you are, so you establish the arteriotomy depth, you advance the system for 3 to 4 centimeters, and then you are set to deploy the patch. And that is what is going to happen here. So you have a very intuitive handling. It tells you what to do. There are 5 consecutive steps. In step 1, you basically rotate the knob and then you expose the patch on the inside. In the second step, you have to pull on the handle and bring the patch towards the arteriotomy. And once you have achieved that, you will see hemostasis in principle. You will start to see hemostasis. And then you need to proceed with the next step. And here Ole is basically also confirming by ultrasound with his left hand that the patch really has been retrieved up to the arteriotomy side. So it's not always clearly visible by echo, but it can help you visualizing what you need to see. And then basically you proceed with the next step, and that is you will push down the lock on the outside of the vessel that will keep the patch in place. So you're closing the hole from the inside and you're closing it from the outside. So there is this closing mechanism on the outside to keep the patch in place. So as you are doing that, you're working over an 035 wire. If you're not happy, if there is no hemostasis at this point, you can take out the system and either reinsert another Percusil ELITE device, or you can consider other technologies if you wish. And then it's about releasing the device. So you first pull the wire. Obviously, from that moment on, you are committed, and then you release, you disconnect basically the lock from the delivery catheter. And then that is how it looks on the cartoon animation. So you have the patch closure from the inside with a lock on the outside. And that is demonstrated here in this Ole's case. And oftentimes you briefly hold, you prevent the skin from tenting, and that's it. You most often will see immediate hemostasis, and oftentimes, or I think in the best practices, you will also neutralize the heparin with some protamine, as you would also consider doing for instance, other for instance for collagen-based closures. And then there is this confirmation of patent hemostasis. And that is then what you end up with. So you have the patch on the inside that will resorb over 3 to 6 months. And this is how it looks from a pathology point of view. So at 6 months, there is nothing left behind. Your vessel lumen has normalized. There is no indentations, no strictures at all. There is a patent vessel. So maybe before we move on to the venous side, some discussion?
Yeah, so let me ask you a couple of questions. So you said it's 3 months for the patch to resorb. If you go back a slide first, it looks like there's quite I suppose, an inflammatory response right at the top of the vessel there. Your experience, have you gone back in through one of these? Is it easy? Do you get a lot of fibrotic tissue? Like, for example, if you cut down to an artery? Or
So obviously, yes, there is an inflammatory response because that's a healing response, and you're adding like foreign body to temporary foreign body material, basically. So that will induce an inflammatory reaction. I haven't re-accessed a percusile closure site so far. I haven't been able, or that was never necessary. At the same time, I've also never seen any issues related to late infections or late device-related complications.
Okay. Guys, any questions for Nicholas regarding this system? While you're thinking, or from you guys, any questions for Nicholas? Inclusion, exclusion criteria, are there particular vessels that you don't use this on? Calcified vessels, posterior calcium, anterior calcium, have you?
Well, I think that the major limitation would be bad punctures, right? So you really want to make sure that you have an adequate arterial access, and that is, as Lisbeth already alluded to, the reason why we always recommend to do ultrasound-guided access, so that you avoid anterior wall calcium, that you are sure that you're secure, that you are in the middle of the anterior surface, a part of the vessel. And I think you want to stay away from the bifurcation. So you want to stay outside 2 centimeters of the major bifurcations. And that obviously also is something that you confirm by ultrasound.
You have a question?
What's the size of patch for a vessel to choose? It looks like for the nodular calcification, or in case if we have anterior calcification on the arterial wall, it might not work as well to provide the seal. So how much of a vessel would you want clean enough for a good puncture for this device?
So you mean
like in terms of in millimeters, should it be like 5 or 10 millimeter good vessel?
You mean good vessel in terms of there's no calcium there?
No calcium, yeah.
Well, I think that as long as you are able to land the patch at the end, you'll be okay. So I'm not so worried about superficial calcium. Obviously, the more prohibitive the calcium gets, the higher the likelihood that you should consider alternative access. That would be my approach. There is, we have seen multiple iterations of the technology, and I think an important iteration was to make the patch thicker and a little bit bigger. And that probably also allows us to cover more of the internal of the vessel, which probably will end up being more effective. But I have not experience with the first generation. I only got experience with the second and third.
And is there any minimal size of the vessel required for this patch?
Well, we use it for up to 14 French and higher. Okay. So I would recommend to stay above 5 millimeters.
Okay.
Yeah.
Thank you.
Nico, one of the difficulties that we see, for example, with a MANTA device is either that the foot plate is not up against the wall, that it gets stuck in some calcium further down the vessel, or indeed that the collagen plug can be pushed into the vessel. Are there specific design features of this patch-based closure that prevent that from happening, that abrupt closure?
Well, from a theoretical point of view, I think you can also get stuck behind atherosclerotic disease as you are pulling back on the patch. So that obviously always is possible. But the beauty is that you have your safety wire still in, and you can then leverage that safety wire for some kind of a bailout procedure that can be you retry another percusile device and try to get away from the atherosclerotic plaque, or you can divert to another closure device system. As I mentioned, you close from the inside with collagen-based closure. You close from the outside, so you need to push collagen down. Obviously, that comes with a risk. It's not common, but it can happen that you will enter the collagen into the vessel.
Okay.
Yeah.
And just a final technical question from my side. At what point is it only when you pull the wire? Because it seems like you lock the device and then you pull the wire. So if you've locked the device, but you still have the wire in place, can you unlock, remove the system and go back in?
Well, I haven't done it myself, but I think as long as the wire is there, you can wiggle your way out of it. Yeah.
The wiggle technique.
The wiggle technique, that's what you do.
Any of you guys got any more questions for Nicholas about his wiggle technique? Yeah.
Sorry, sir. I'm sure.
There's a microphone here if you want to grab it.
Well, you kneel down and then you.
It's for very small people.
Sorry. Just double check regarding the technique. I didn't catch regarding the anchor. So we are saying that the patch is dissolving, right? And where is the anchor at the very end? Because
You
it's,
mean on the outside?
yeah, the upper one. Yeah, exactly.
That is also resorbing by 6 months. That's
okay,
up.
perfect. Oh yeah, thank you.
Yeah.
I didn't get it from the beginning. Thanks.
So the whole thing, the internal patch and the external lock is all resorbable.
So the internal patch starts to resorb by 3 months, and then by 6 months the entire assembly is gone.
Okay, Vaz.
And the other thing I want to point out is that for those ultrasound users, when you're deploying patches or collagens, you can do it with a manta. You can check it with ultrasound to see that the anchor is coming up. But obviously, you can imagine with the PerQseal, it's much easier because it's a much bigger, basically, patch. So it's much easier to follow it on your ultrasound to make sure that it has a post. And then after that, probably things are easier.
Well,
But not
you have to
necessary,
manage
right?
expectations there. It's not always easy to
The moment
demonstrate
you've got
that.
any form of bleeding going in and a hematoma, that's your ultrasound picture's gone, right? So I think we all know that. I mean, we all have that limitation. But in terms of, it's a bigger size compared to the anchor of the manta. So it might be easier to follow that bit if you have a good window.
Okay, Nico, thank you. We're going to come back to the venous closure because I think that's really a really unique and interesting feature.
Yeah. So
so we're going to come back to that.
Later on?
Yeah.
Oh, okay.
Yeah, that's so Raj, you're going to give us a case of arterial closure with a clinical scenario that required something a little different. And then we're going to come back to Nico, who's going to give us his recent experience of venous-based closure using the PerQseal device. So Raj, over to you.
Thank you. So I'm just going to briefly review one of the cases that we had done recently that was part of a live case. These are my disclosures. So this was an 88-year-old gentleman with a history of hypertension, hyperlipidemia, type 2 diabetes mellitus, who initially presented with CCS class 3 dyspnea on exertion that was felt to possibly represent, it was kind of unclear as to whether they were anginal equivalents or whether it was related to his aortic stenosis. He obviously was found to have severe AS and a mildly reduced ejection fraction equaling 45%. I've included a couple of shots of the aortic valve just to show you how calcified the valve was, and there was gradients over there just peaking over 4 meters per second. This was his baseline angiography that was performed while we were working him up and evaluating him. As you can see, there's a very heavily calcified lesion in the proximal right coronary artery. In addition, he's got diffuse calcification kind of spanning across the left main into the proximal LAD, and then a reasonable lesion here in the proximal and then the mid-LAD. All of these things were CathWorks positive. CathWorks is off-label for the use in AS, but we use it quite frequently. But all of these were evaluated. So the left main stenosis, although angiographically not that impressive, was physiologically significant. We went ahead and got a pre-procedural CCTA, and as you can see here, his access is pristine on both sides. So our procedural plan for this gentleman, who was really against having more than one large bore access procedure, was to proceed with a single access Impella-assisted PCI, utilizing Abiomed's new companion sheath with rotational atherectomy and IVL of the right, followed by rotational atherectomy of the LAD and left main, to be followed with withdrawal of the Impella device from the same access site and then performing a TAVI through that arteriotomy utilizing a SAVI wire.
It's like a month's work, Raj. I'm tired just looking at that schema of events that you're going to have to manage. So.
Yeah, it was a bit of a protracted live case, but it was actually our first live case ever from this institution, so it was a good one. We had actually applied to use PerQseal for this procedure, but the FDA really restricts the use of investigational devices, so we had to pivot and went with the strategy that Elizabeth had touched base on with regards to the use of one perclose and then finishing with an 8 French angioseal. So our access technique is kind of standard. It's ultrasound guided for everything. We don't really use a lot of micropuncture unless we're using alternative access, but one perclose was pre-deployed here. And then we went ahead and did rotational atherectomy and IVL of the right with the Impella in place all through the single access site. Got a nice post-dilatation there with a large stent with a reasonable angiographic result there. The post-PCI FFR was 0.97. We went over to the left side and again used the same rotaburr and kind of worked our way from the left main into the LAD down into the mid portion. Finished that up with 2 overlapping drug-eluting stents with a very reasonable angiographic result there. The FFR value post-PCI was 0.94 in the distal LAD. And then pulled the Impella device out and then went in with the TAVI wire. This gentleman measured to a 26 millimeter S3 Ultra with Resilia, which you can see a nice 90-10 deployment there with really no issues whatsoever. And then afterwards, this is our post-TAVR implantation aortogram, where you can see there's trace AI, but that usually resolves after protomine and on the follow-up echo. And then there's our final closure utilizing that 8 French angioseal. So this gentleman was kept in the hospital and discharged on day 2. So far in the United States, we've participated in 2 of the early feasibility studies. The Impella EFS was first, where we had a total of 19 patients, 7 of which were in cardiogenic shock at the time of deployment, which I think speaks to some of the utility of this device in the, MANTA is somewhat limited in the sense where you have to have pre-measurements unless you're very facile with ultrasound. You can see the technical success on both the Impella and TAVI side is 100%. Really, the time to hemostasis is less than 3 minutes in most instances. And there were really no major vascular complications associated with the use of either device, which is why we felt it would be applicable for this case scenario. There were 2 minor issues as it relates to minor access complications, and both of those were pseudoaneurysms with a small hematoma. However, the hematoma, again, in somebody in cardiogenic shock and is kind of wiggling around is really not that unexpected. So overall, our success and kind of zeal for the device is very good. The IDE patch study that's ongoing now is utilizing the PerQseal Plus device. Again, as Nick had pointed out, it's utilized in 14 to 24 French arteriotomies. The goal is to enroll about 190 patients. So far, it's 2/3 enrolled to date. Again, we're looking at major access site complications at 30 days with the efficacy side endpoint being time to hemostasis. So we first started in April 2023 and hope to finish enrollment by hopefully April of this year. So in conclusion, I think vascular complications are something that we see despite the use of and growing use of best practices for vascular access and closure. When you look at a lot of different data points, the rates of vascular complications and cardiogenic shock in particular estimate around 10 to 13%. In protected PCI, they're as high as 10%. So having some new novel techniques and devices, I think, applicable to this space is really, really helpful. So I feel like this is a great device kind of moving forward for the future. Thank you.
Super, Raj. You got a beautiful result on that PCI. Really, really impressive. So let me get your gestalt on this device, because we've had this promise before, right? We've had this promise of large bore closure devices, and ultimately, whether we look at it from day-to-day clinical practice or whether we look at it in clinical trials, we really haven't seen that they are widely used or usable for a vast majority of patients that we see from day-to-day clinical practice. Your patient had the most beautiful femorals. We tend not to have femorals like that in the west of Ireland, unfortunately. We drink too much Guinness. Is this device the type of device that you can take off the shelf in pretty much every TAVI or Impella case and get a good result? And I'm conscious that the company are in the room, but we need to understand where are you gonna use it?
Yeah, I mean, I don't think that there's any one device that's immediately ready to come off the shelf and applicable to every single anatomy. I do think that this offers a broad breadth of the ability to be relatively flexible. It's safe. I think, when MANTA was first released, there was a lot of interest and a lot of hype around its utilization as the one large bore kind of solution for large bore arteriotomies. The issue, however, again, relates to the depth measurement, the lack of wire access, 2 of which of those problems have been solved by the use of this device. I also think that the bioabsorbability component plays a large role in our desire to utilize it because it makes it very attractive for reaccess and whatnot. So I think it does move the needle forward. Again, I don't think that there's a perfect solution for very, very heavily calcified access, things like that. We have anecdotally come up and over and shockwaved very calcified femorals. and treated the anterior calcium with shockwave and then perclosed them in some instances. Obviously, in the context of a clinical trial, we're not going to do that with this device, but I think that as we push the envelopes more, we'll see that as the patch has gotten thicker, you'll be able to get away with more and more utilizing it.
Okay.
And maybe one question here. So in the shock patients, then you can just use it bedside also. You don't have to do it in the cath lab.
That's exactly right. So we'll just go up to the unit and take the impella out. You have wire access and just put the sheath in. It works beautifully.
I agree with that. I think it's a very attractive indication for PerQseal technology. Why? Because you don't. So if you have patients on mechanical circulatory support in the ICU, you preferably don't want to have pre-closures in situ because it can infect and it is a mess, but also with the nursing care in the ICU. And according to the IFU, you cannot use the MANTA device because most often you have been putting in the mechanical circulatory support in a more stressful environment during an acute situation, so you did not have the time to do all the arteriotomy measurements. Well, all those things you don't need with PerQseal, right? You can just exchange the large bore mechanical circulatory support sheath, and then you're on your way.
Two more questions from my point of view, and please, if you guys have any, shout them out. High bifurcations, femoral, the common femoral heading back into the pelvis, into the retroperitoneal space. Do you think that's an application? And then second, obviously, sometimes with those high bifurcations, you've got a really beautiful superficial femoral artery. Can it be used in a superficial femoral, unlike perclose, where you can get the arms stuck on the bifurcation?
Yeah, I mean, I think those are great questions. I think anytime you have very high bifurcations that kind of tend to dive down towards the pelvis, getting the angulation in the arteriotomy is very challenging. So I think there's a high default of having a lot of residual extravasation. So I would prefer to use the SFA. And I think as long as the vessel's 5 millimeters or greater, you should have no issues doing this. Andy, I can't wait to try it in the arm, by the way, too.
Okay. Transradial TAVI. Raj, I like the sound of it. Any questions from the audience at all? Okay, with that, Raj, we're going to move on. So, Nico, you're going to come back and you're going to flip through your presentation and tell us about the potential application of this device in the venous circulation. So, interesting. An interesting application. Do we need it? Maybe would be my first question. Let's see what you say.
Well, I think that is a very good question, and I'm also not convinced that we really need another dedicated closure device technology for venous access. That said, we know, for instance, in the Apollo EU trial and in the Apollo trial in the United States, there was surgical access required. So for venotomies above 30 millimeters, there was the recommendation to do surgical access. And obviously, as we are moving to the venous space, to TMVR, TTVR, tears in atrioventricular valves, we are exploring more and more large bore venous access. And this is a summary of what we're doing these days in terms of venous access. So we go all the way to 35 French with the Intrepid system. But you see that there is definitely an accumulation of large bore venotomy devices in the context of TMVR and TTVR. Also, the ECMO venous sheet oftentimes is 25 French. So the question is there, okay, is the suture then the way to go? In principle, I haven't experienced a lot of issues with venous closures up to 28 French. I also use venous closure with sutures in the ICU when I take out the ECMOs, although that is a little bit more bloody. So if you really want to be as clean as possible, that is, I feel, where new technology may become reasonable. And also if we approach 30 French and higher, there's also maybe an idea to consider at least other technologies. And this is an example of a patient who was treated in our elite venous cohort. So we exchanged a 24 French system sheet for the venous sheet, for the percusile sheet, and then you ask yourself, yes, but okay, you did a TEER procedure. In principle, you don't have a sheet there. Well, we do have a sheet because we are doing a lot of research in terms of pressure volume loop analysis. So then we have to take out the delivery catheter over the wire, reinsert a 24 French sheet, and then do our PV loops. Okay, it's an academic exercise, but that's why we need it, and that's why these patients also come on our radar. So there is no pre-closure done or anything. So we exchange the sheet for the percusile sheet over an 035 wire. You know, the moment they transitioned from the 018 to an 035 wire, I mean, it became much more user-friendly. And then again, you do the same thing. You advance the catheter until you see the blood coming through in the sideport, and then you pull back until it stops. That is where your venotomy is, the depth of your venotomy. And then you reinsert for 3 to 4 centimeters. That's what we're doing here. And then we're all set for the deployment of the patch. So obviously when you reinsert for 4 centimeters, then it will start bleeding again. So that's why we close the side port, just to give us a clean working space. We reinsert or we insert the patch assembly, we click it and connect it with the sheath. And then it's the same step. So we are very horizontal, only a 10-degree angle, if you will. And then the first step is that you expose the patch on the inside of the vessel. And then you need to pull back all the way to the venotomy. You open up the side port again. So that will give you some feedback, because it's not always easy to have the tactile feedback with the patch at the venotomy. So when it stops, when the bleeding stops, then you know that you have connection with the venotomy, and then you can proceed with the lock, and then you will see immediate hemostasis. We did now 4 cases, and this is the result in all 4 cases. So it really works very well in the venous space. Whether it's really covering an unmet clinical need, you can debate that, but I think it definitely can make your procedure cleaner. And again, if you are considering taking out ECMOs percutaneously in an ICU setting, this definitely is a nice technology.
And again, if we look at major vascular complication rates in the many series of tricuspid valve replacements, they're 10%. And major vascular complication rates in the venous situation means you're going to surgery.
Yeah.
It's not a covered stent. So 1 in 10 patients going to surgery because of a venotomy issue. So do we need it? Hopefully not, but on occasion, yes.
Yeah.
So very interesting.
And this is maybe the heads up where we are now with the ELITE trial. So there is the ELITE, the percusile ELITE and the arteriotomies, where we are now 34 patients in, and we are continuing to enroll patients. And we just started. We have 5 patients enrolled now in the percusile ELITE, the venous part.
Quick question for you, Vaz, just about the venous. Does it worry you that the patch could reabsorb? Or that as it reabsorbs, that there could be some fragmentation and you could lose particles towards the pulmonary circulation? Is that possible, do you think, given your experience?
Not really. I think normally it gets encapsulated by the body, a bit like the bioresorbable stents. So you wouldn't just, it wouldn't just fracture and then start flying around. So I think that solves that problem. And it's actually, again, attractive, particularly for people also that undergo ECMO. That sometimes, these people might need it again later on in life. So it's good to have a decent venous site left. And as you said, whether it's needed or not, I think the debate is out, but 10% is quite a big number.
So if no further questions, I think time to wrap up the session. I'd like to maybe reiterate some of the key learnings for me. Elizabeth took us through the various steps in terms of vascular access and closure, good CT analysis, ultrasound-guided puncture, and a bailout plan always. And what I learned maybe is transitioning towards an alternative access approach that Raj and Nico use quite liberally, and I certainly don't in my institution, may reduce those vascular complication rates. Nicholas took us through a very nice patch-based closure case from Riggs Hospital. We saw immediate hemostasis, and we saw that the system is very easy to use, and that it removes some of the previously mentioned issues in terms of reaccess, depth measurement, and so forth that are associated with other closure technologies. Raj took us through a really complex case that was pretty impressive for a live case, Raj, but also showed to us that we can get really good outcomes with the multi-close algorithm using a combination of suture and plug-based closure. And then Nico polished it off with the application of the perc seal device for venous closure, which looks certainly very interesting. And I certainly have sent patients to surgery even after a MitraClip procedure, quite unusually. So with that, I'd like to thank you guys for attending, thank the speakers for their expertise, and VivaSure for sponsoring the session. So if you have any questions for the panel, please come up towards the end. We'd be happy to hang around and have a discussion. And thank you for spending your time with us. Enjoy the rest of the course.